Go ahead, Sandy.
Okay, I think I'm off mute now. Hi, I'm Sandy Werner. I'm one of the PTL Probing the Literature organizing group, and I would normally put up some slides, but I had trouble getting to the location I needed to be at, so I don't have them in front of me. But I think Dan may have gone through kind of the rundown of the show. We typically have an author for discussion for the first 25 minutes or so, and then we break up into small groups and discuss a second article. So I'm going to introduce to you Dr. Ralph Wang. And he is going to talk about his article, Effect of Ultrasound First Clinical Decision Tool in Emergency Department Patients with Suspected Nephrolithiasis, a randomized trial. And Dr. Ralph Wang is a professor at UCSF, and he's also the director of research. So he actually does research beyond ultrasound. So a great resource for us. So he trained at Highland Hospital in Oakland, California for residency, and then did a POCUS fellowship at Highland. He was actually the POCUS fellowship director at UCSF for a number of years and was conducting research in ultrasound on ectopic pregnancy, and he was the PI for the STONE trial comparing CT versus ultrasound versus POCUS, which this article is actually based on. So right now he does research on a lot of topics, including ultrasound. And he also said, hey, he'd be happy to talk with fellows who are interested in research. So with that, I will turn it over to Dr. Wang, and maybe you can give us a brief discussion on the STONE trial as an introduction or background to this. Thanks.
Yeah, thanks for having me, Sandy and group. I really appreciate the chance to talk about this work. So what and I should say that I was the site PI for the STONE trial. The STONE trial was PI was a radiologist at UCSF, Rebecca Smith-Bindman. Anyway, I'm going to talk about this article, the study that I conducted, Effect of Ultrasound First Clinical Decision Tool in ED patients with suspected kidney stone. And thank you so much for inviting me here. I don't have a conflict of interest to declare. This study was funded by an internal award called the Learning Healthcare System Award at UCSF. The background is that I think CT scans are overused for suspected kidney stone. Not everybody with suspected kidney stone needs a CT scan. 80% of patients are diagnosed with a stone, receive CT, but very few of them require admission or have a serious alternative diagnosis. And CT can be harmful. It can, CTs are associated with radiation exposure, which can lead to increased risk of cancer and also incidental findings. So one solution to reduce CT overuse is an ultrasound first strategy, which I know everybody in this room knows about. I was a site PI for the STONE trial, which was conducted in 2014. And this was a multi-center ED-based randomized trial comparing CT to point-of-care ultrasound and radiology ultrasound. The primary outcome was misdiagnosis. And these misdiagnoses included cholecystitis, appendicitis, bowel obstruction, ovarian torsion, and of course, AAA. The other co-primary outcome to this trial was radiation exposure. And the results suggested that an ultrasound first strategy could reduce CT use and radiation exposure without increasing the rate of misdiagnoses. So that's the background to that trial. The reason why I conducted this study is that even though we published that article in 2014, ACEP came out with a Choosing Wisely campaign that stated that you should avoid ordering CT in young, healthy patients with a past history of stone. So there were a lot of efforts to reduce CT overuse, but it didn't work. And as you can see in this study by Ganesan, published in JAMA IM last year, CT use has just increased over time. These authors used the NEDS, the National ED Sample, to look at CT use for patients with suspected stone, and it's just been increasing. Stone trial was published in 2014. Choosing Wisely was published in 2014 as well. So publication of this trial is not sufficient to incorporate an ultrasound-first strategy into practice. So my thought was to try to study an implementation of a ultrasound-first strategy. Any questions about that? I'm seeing some nods, no questions. Okay. So my objective when starting this study was to develop a decision tool based on the stone trial to encourage ultrasound first strategy, and then to see if implementation of this decision support tool would decrease CT use, and to see if it would decrease radiation exposure. And finally, the balancing hypothesis was that it would not increase healthcare utilization. Any questions about that? I'll keep going. This is a pretty big slide, but I'll just kind of go slowly through it. The study design was a 1-to-1 randomized trial in which ED providers were randomized to either receive the decision support tool or not. We did this study at the UCSF emergency department. It's an academic ED with residency trainees and yeah. The participants were the ED providers who ordered a CT scan of the abdomen and pelvis for a patient with suspected stone. And the way I triggered the way I kind of captured these providers and triggered the decision support tool was through the reason for exam. So if an ED provider ordered a CT scan and put in a reason for exam that had any of these terms like stone, renal, hydro, nephro, or flank pain, they were in the study. I excluded patients who, at the extremes of age, not that less than 18 or over 75 is extreme, but that were less than 18 or greater than 75. I excluded them if they had already gotten an ultrasound during that ED visit. And then past history of kidney transplant, end-stage renal disease, obese patients, and fever. These exclusions were taken basically just right out of the stone trial exclusion criteria. The intervention is a ultrasound first decision support tool. I'll show that in a second. The outcomes are the proportion of patients who received a CT scan during their ED visit. And the other outcome is radiation dose in millisieverts and ED return visit. at 3, 7, and 30 days. I analyzed this data basically looking at point estimates and a risk difference of the point estimates and 95% confidence intervals. I calculated a sample size by saying, well, I think if you order a CT scan, the risk of completing that CT scan in the control group is 99%. So if you start ordering a CT scan for kidney stone, 99% of the time that order is going to be completed. And I thought the intervention would reduce CT use by about 10%. So 216 participants were needed. Any questions about the methods?
No, I think it's a good idea to just kind of mimic a lot of the baseline stats from the stone trial to move this literature forward. It makes a lot of sense.
Cool.
Can I just ask about your randomization of the providers that you had mentioned?
Yeah.
I was just wondering how that actually happened, and was it like case by case? Because some of them, I just wasn't sure how, when you did that randomization and how they were kind of chosen to use a clinical decision tool and not.
Yeah, so it's really when they ordered the CT. When they ordered the CT that matches a kidney stone CT, and they don't have any of the exclusions, that's when they get enrolled in the study, and then half of them are randomized to receiving the decision support tool.
So could they also be, I was just wondering, could they also be, is this just like every day you were doing this? Or I was just wondering, like, a certain faculty working different days, do they, when they order something, it pops up and then they get randomized to be using the clinical decision tool or not using it for that day on that particular patient?
It's
so some days they did it and some days they didn't. Is that what you're saying?
Yes. However,
Okay.
it's usually the ordering physician and not the attending physician. So it's whoever's putting in the order.
Yeah.
Okay. And that would include like residents and APPs and sometimes attendings. And so I know what you're getting at, and that's one of the limitations of the study is contamination. Okay. But I'll
Okay.
talk more about that.
Okay, thanks.
So the conceptual model here is that, and maybe this can kind of help with that question. The provider orders a CT for suspected kidney stone and they're enrolled. And then those randomized to the intervention arm get, they see this decision support tool and they encounter the tool, and then they hopefully change their CT order to an ultrasound order. That's how this is intended to work. And this hopefully would reduce CT scans and radiation exposure. Down here, it says that there's no, that the intervention is delivered by the electronic health record. So this is all within Epic. We didn't have a research coordinator doing informed consent. And then all of the outcomes are measured by the electronic health record. So I didn't do any follow-up visits or anything like that. I just looked in the electronic health record and extracted data. And that is part of the learning healthcare system concept that you can that you can conduct research using electronic health records only. So this is what they encountered. This is the intervention. I'll just read it from top to bottom. A kidney stone was, a CT scan for kidney stone was ordered. And sorry, the inclusion criteria were age, obesity, the patient had to be low risk of a stone emergency. So if they were febrile with an obstructing stone, they weren't in this study. And also if someone, you know, had a risk of an alternative diagnosis, like they had a pulsatile mass in their abdomen or something like that, they wouldn't be in this study either. If all of these are true, the provider is asked to remove the CT kidney stone and then to order an ultrasound. And then if they refuse to do this, that's okay, but they had to give us a reason. So what happened, we enrolled about, we screened about 583 people. The majority of them, about half of them, already had an ultrasound completed. So they were out of the study. But we did randomize 254 patients, 128 to the decision support arm and 126 to usual care. They didn't see the decision support tool. Because there's no research coordinator or follow-up visits, there was no loss to follow-up. Everything was captured in the electronic health record. This is probably too big to discuss so I'll just point out, this is the kind of typical table 1 characteristics of the study participants. The patients were in their 50s, median age was 54, about half female. And the reasons why people got into the study were, so these are the reasons for exam listed on the CT order. A lot of people had flank pain or kidney stone or nephrolithiasis as the reason for exam. And only 20% of cases were ultimately diagnosed with kidney stone. And I'll talk a little bit about why I think that what happened with that. That seems a little low to me. These are the outcomes of the study. So the top line outcome, the top row is CT scan completion. So in the ultrasound first arm, the intervention arm, about 87% still went on to get a CT. And in the usual care arm, about 94% still went on to get ACT. And so the risk difference was 7.7 with confidence intervals that indicate statistical significance. Renal ultrasound completion was also increased in the decision support tool, the intervention arm, 18% versus about 12%. But this did not reach significance, and the total radiation dose was about the same, and the cost was about the same. This is the balancing safety outcome, which is ED revisit. So the idea here is that if you're asking providers to not get a CT, did those patients come back? So we just looked at 72 hours, 7 days, and 30 days at ED revisits. And just looking at this, for some reason, the decision support tool resulted in fewer revisits, or was associated with fewer revisits at all of the time points. So here you can see, 2 out of 128 versus 4, 5 out of 128 versus 12, and 16 versus 25. So for some reason, there were fewer revisits in the intervention arm, which was surprising to me.
So, Ralph, just can I ask, so did you how big of a system is this? And were people perhaps likely to go to a different hospital?
Yeah, that's a good question. This was in the this is only in the UCSF health system and not across the entire city and county. And so yeah, that's one of the limitations to this electronic health record way of ascertaining ED revisits is you can't get everyone. So the discussion, this was, I think, the first study to determine the effect of a decision support tool to reduce CT use for suspected kidney stone. Implementation of the decision support tool resulted in really just a modest reduction in CT use, 8%. But the number needed to treat to avoid a CT scan would be about 13. So for every 13 times a provider encountered this tool, they would have one less, they would order one less CT scan. There was no difference in radiation dose, and I'll say that's because I made a mistake, which is in the next slide. So I'll talk about why I think that is. And there were no differences in ED revisits. So if anything, there was a trend towards increased revisits in the no CDS arm. So the lessons learned, there were many mistakes made in this trial. And I think the first one is the study participants. I included CT scans with contrast, and that was purposeful because I looked initially at the kinds of CT scans that were in the emergency department that were associated with a kidney stone diagnosis, and a third of the time, ED patients diagnosed with kidney stones had gotten a CT scan with contrast. So I thought, let's just get everybody. But I probably should have excluded them and only included CT kidney stone like without contrast, unenhanced CT. And that's because the CT scans with contrast, I think, represent a different group of patients who are not just simple kidney stone. They're at higher risk of alternative diagnoses. People are ordering CT scan with contrast for another reason. And I should have excluded them. I personally think this would have increased the reduction in CT use. And I also think that this is related to why there's an increased radiation dose in the decision support arm, because I think we weren't able to account for the increased radiation in CT scans with contrast. So I should have just kept it kind of simple and just targeted it to that group. The second mistake I made was that we didn't capture data in the initial imaging order. And this gets very complex and hand wavy, but suffice it to say that when you order a CT, that the first order is a parent order, but then that order gets modified by radiologists and sometimes modified by the provider. And there's this, what comes out is this whole history of a particular order. And this complexity really prevented us from determining the type of CT that was initially ordered, which made our analysis really difficult. anyway, so I think if I were to do this again, just CT scans without contrast, capture the initial order more clearly, and then and probably because decision support tool studies often are conducted using cluster randomization rather than individual randomization, because providers that saw this tool over and over again would tend to learn that they were going to see this decision support tool, and that might have resulted in contamination. So probably next time we would do a cluster. That's it. Would love to hear questions, comments.
There was
Ralph.
I'll let this
Oh,
gentleman.
go ahead, Dan.
And then afterwards, there's a question in the comments.
Go ahead.
From the comments, Dr. Loney had asked, what about if the patient had a point of care ultrasound performed by ED docs and were discharged without any comprehensive imaging, ultrasound, or CT scan?
Great question, Becky. So that person was excluded from this study. If you had a CT, if you had an ultrasound that was ordered initially, you didn't have to go through this decision support tool. We didn't want to stop people who had done a point of care ultrasound and thought, I really need a CT here. We didn't want to prevent them from doing that. And that is, that's reflected in the strategy, which is ultrasound first. So I think we should just let ED providers order what they want to order, but we do want to encourage them to use ultrasound first as kind of the first line. If they're not, seeing what they want, or if they're not getting the answer that they want, then by all means order a CT.
Ralph, could I, it's Pat Hinfey from New Jersey, just a kind of a multi-pronged question. As I've incorporated this, really pretty fully into my workflow, I tend to use the stone score. I just pop into MD-Calc and kind of modify what I'm doing based on that. And, any thoughts to incorporating that? That's piece one. And then I would wonder if it's something I kind of put in over time, but searching for a UVJ stone has kind of made me just find them. I say, you know what, this is what we've got. We're done here. And I think it's kind of allowed me to get a little more comfortable. And I don't know that learners come out knowing that kidney stones only hurt when they go down your ureter, causing spasm or obstruction. And I think I kind of had to learn that over time. And I think it's allowed me to really cut down the CTs a lot. And I wonder if you noticed or thought that the experience level of the doc overseeing the case had any effect on that outcome.
Yeah, great questions. I think seeing a stone is great. Like, if you're able to take your skills to the next level and look for UVJ stones, I think that's that really increases my certainty that the patient has a stone. And I do find that it's a very useful sign, and I personally look for it. I will tell you that there's certain technologies that are being tested right now that are looking at breaking UVJ stones at the bedside. And so that is a skill that we should all continue to work on. The stone score is, I did an external validation of the stone score. I think it does predict stone pretty well. 1 minute remaining. I just don't know that there's a established algorithm that combines stone score and ultrasound. I think, I'm sure Chris Moore has published on combining stone store and ultrasound. So I kind of leave it up to him. Sorry, I think I'm out of time, but I really appreciate it, and thanks so much for listening.
There's one more question from Dr. Melniker that I see. So let's go ahead and take that question, and then we'll move on.
Hi, Sandy. Thanks, and thank you so much, Ralph. Great study. Your description of its limitations, I think, is quite robust, and it's always good to see authors who are self-critical. In terms of the score, I mean, most scores are just objectifications of Gestalt, and I think Patrick's point is well taken, that with 64 different providers in your study, you'd have to see, rather than thinking about a cluster RCT, which is very hard to do, if you have enough patients, you may be able to do a multi-layered regression so that you can control for the experience of those 64 different providers, and that might give you more information. My shop does non-contrast scans and contrast scans. Some shops, I don't know whether yours is included, always does a non-con quickie look and then gives contrast and does a contrasted study. So you should definitely see what kind of protocol, because the radiation dosing numbers are not that easy to understand. In terms of radiation mitigation, this is the reason why Chris did his study and Vicky did hers, is because this is perhaps the lowest lying fruit in the radiation mitigation world. In my shop, when they came up with the stone scan, if someone brought their spouse in with renal colic, both the spouse and the accompanying spouse got a CT scan looking for stones. It was so damn easy to do this this study. If you find an old edition of Tintinelli or Rosen's and you look up the section on renal colic, there were written criteria for the imaging of the renal colic patients. There were 3 criteria. One was that someone only had one kidney. They were born that way, they lost one, whatever, they only had one kidney. Obstructing your one kidney is a much bigger deal than one of your pair. The second was that you had what you covered, and that is a potentially obstructed UTI, a pyelo with an obstructing stone. That's otherwise known as an abscess, an infection with no place to go, and represents one of the few true urologic emergencies. The third criteria was intractable pain, which was not described, which meant if you had imaging from 9 to 5 and your patient came in at 10, it might mean 6 hours of pain, and if they came in at 3, it might have meant 1 hour of pain. You will not find a sentence in the paragraph about the size of stones. There is not a single shred of evidence that an emergency physician needs to know the size of their patient's stone. There's plenty of evidence that a urologist may need that information. The stone score that was talked about is mostly a urology phenomenon. So you have to keep in mind what you're doing for yourself as an emergency care provider and what you're doing for the next person coming along. I would definitely look back at your data and glean out these so-called stone scans, because the only time, I don't call them stone scans, the only time I do a non-con CT is when my differential is robust, when I can't get a good look at an aorta and I want to. So it's the patients who might have renal colic but might have X, Y, or Z that are the best candidates for doing CTs. But when your stone score, when your gestalt is very high on the renal colic list, it's unlikely that you're going to get a whole lot of information on top of that. Once your patient has a good story, some blood in their urine, some hydro, you're probably well over 90% fidelity diagnostically, and you're doing a CAT scan for 5 or 10% fidelity. It's just not a great bang for the buck. And you could also secondarily include some of those patients who didn't get a CAT scan order, who just were screened with ultrasound, and compare those two groups as well. Thanks so much.
All right.
Great
Dan?
ideas. Thank you.
So we do have to move to our small group section. So we have 4 rooms available. Andrew, Sandy, Lynn, and I are going to run those. I'm gonna
And
stop
Sam,
the-
Kate,